Today we will discuss about biology of tooth movement. So the topic will be dealt under following headings: introduction, what is tooth movement, orthodontic tooth movement, biological control mechanisms or theories which lie under orthodontic tooth movement, biochemical reactions, phases of tooth movement, orthodontic forces with respect to their magnitude and duration, and tissue reactions to orthodontic forces, factors influencing the orthodontic tooth movement, and conclusion. What made orthodontic treatment so easy, or what made it possible for the tooth to be moved? It's nothing but the periodontal ligament is the main tissue in which the biological reactions occur in response to orthodontic forces, and the tooth will move in response to orthodontic forces. This facility is available only in mammals in general and human beings specifically. Whereas in organisms which were prior to us, like primates, the teeth were ankylosed in their sockets in the respective jaw bases. That means, due to the fusion of the tooth roots with the adjacent bone, it was not possible to move the teeth in primates. Whereas in mammals and specifically in human beings, due to the presence of periodontal ligament intervened between the tooth root and alveolar bone, we are able to move the tooth by means of orthodontic. We are able to move the tooth by means of orthodontic tooth movement. Now, in response to orthodontic force, there are various biological processes that happens in the periodontal ligament, because of which a tooth will ultimately move. Let us discuss about those biological reactions that occur and various aspects related to the orthodontic tooth movement. Tooth movement can be a physiologic tooth movement, pathologic tooth movement, or orthodontic tooth movement. Before entering into the orthodontic tooth movement, let us know what is a physiologic tooth movement and what is pathologic tooth movement. What is a physiologic tooth movement? It is nothing but the movement of the tooth that naturally happens in the oral cavity as a means of process of eruption and as a means of maintaining a continuous occlusal and proximal contact with the adjacent teeth in response to the occlusal wear and proximal wear. That means, movement of tooth during the process of eruption is a physiologic tooth movement, and due to repeated mastication, there will be occlusal wear of the occlusal surfaces of the teeth. In order to overcome this, and in order to keep a continuous contact with its opponent in the opposite arch, every tooth in the jaw has a tendency to move occlusally as well as mesially. So this process of movement of the tooth is a physiologic tooth movement. What is a pathologic tooth movement? It's nothing but movement of the tooth as a response to pathology is called as pathological tooth movement. For example, if a patient or if a person has deleterious oral habits like tongue thrusting habit or thumb sucking habit or any periodontal pathology, then the teeth will start migrating in the oral cavity. That means the teeth will tend to move in response to these deleterious forces. This is the effect of pathology, and this type of tooth movement is called as pathological tooth movement. And one more aspect is, for example, if we have a premature exfoliation of a particular teeth in the dental arch, then the tooth distal to it most commonly tries to mesialize itself or tries to occupy the space created by the exfoliated tooth. This is also a kind of pathological tooth movement. Whereas the orthodontic tooth movement is the movement which is induced in the teeth by means of an orthodontic appliance, whether it be a fixed appliance, a removable appliance, or a orthopedic appliance. Now, coming to the orthodontic tooth movement, there are about three valid theories that are proposed to explain how a tooth or a group of teeth move in response to orthodontic force. These theories are pressure tension theory, bioelectric theory or piezoelectricity, fluid dynamic theory or blood flow theory. Let us discuss about each of these theories of orthodontic tooth movement one by one. The first theory is pressure tension theory proposed by Oppenheim and Schwarz. According to this theory, when an orthodontic force is applied on a tooth or a group of teeth towards the direction of force in the periodontal ligament, there will be generation of the area of pressure, whereas on the other end there will be generation of tension. Always remember, whenever there is a pressure laid on the bone will undergo resorption, whereas when a bone is subject to tension, a new bone will be formed in the region of tension. Similarly, in this aspect, whenever there is a pressure concentrated in the periodontal ligament, there will be a narrowing of the blood vessels. It's not complete obliteration, it's a narrowing of the blood vessels. As a result, what happens is there will be localized hypoxia that is created. In response to this hypoxia, an inflammatory process is generated which will lead to production of number of interleukins, cytokines, TNF alpha and prostaglandins. These are the inflammatory mediators. In response to the generation of these inflammatory mediators, the macrophages from the local tissue will get differentiated into osteoclasts. Along with that, the circulating monocytes will also come and get recruited in the area of pressure or area of hypoxia, leading to their conversion into osteoclasts. These osteoclasts will ultimately cause resorption of the bone on the pressure side. Whereas on the tension side, there will be increased supply of the blood due to the dilation of the blood vessels, increased number of anabolic components supplied in the region of tension, and there will be differentiation of osteoblasts leading to deposition of the bone. That means the pressure tension theory says that due to orthodontic force, areas of pressure are generated on the side towards which the tooth is moving, whereas on the opposite side in the periodontal ligament there are areas of tension created, and thereby a cascade of biochemical reactions occur leading to resorption of the bone on the tension side and deposition of the bone on the pressure side, because of which the tooth will ultimately move and the socket will get remodeled to hold the tooth in a newly moved position. Okay. The next important theory of orthodontic tooth movement is bioelectric theory or piezoelectric theory. We call it as bone bending piezoelectric theory. It was proposed by Farrar. What this theory says is, whenever an orthodontic force is applied, there is distortion of the crystal lattice present around the tooth, that is in the periodontium. The structures that are distorted include the alveolar bone, the cells in the periodontal ligament, the hydroxyapatite crystals, the mucopolysaccharides, and the collagen fibers. Due to the distortion of these structures, there will be flow of electrons from one portion of the crystal lattice to the other portion. This flow of electrons is called as piezoelectricity. Further, these electrons will be bathed in the fluid in the periodontal ligament, creating streaming potentials in the periodontal ligament fluid. Creating an electric potential in the periodontal ligament fluid, and this is called as streaming potential. So, in response to orthodontic force, there will be distortion of the periodontal tissue, which will lead to generation of piezoelectricity and streaming potential. As a result, the distorted structure or the distorted crystal lattice will be charged That means suppose this is a crystal lattice, whenever a crystal lattice is distorted or bent in response to the orthodontic force, along the concave side you can see actually a negative charge, whereas along the convex side you can see a positive charge. Whenever there is a negative charge, there will be bone deposition. Whenever there is a positive charge, there will be bone resorption. In this manner, in response to orthodontic force, generation of piezoelectricity and streaming potential and change in the uh, you know uh, the surface potential of the bone, there will be bone deposition on the concave side, whereas resorption on the convex side. This is how the bone gets remodeled in response to the piezoelectricity. But when we look into the characteristics of piezoelectricity, the electric current that is generated in response to orthodontic force is of very short duration. It will undergo a rapid decay rate, number one. Number two is, whenever the orthodontic forces are removed, the electric potential will change. That means the charged negative and positive surfaces will get reverted back into their normal form. That means piezoelectricity is only of short duration. In response to continuous forces, the piezoelectricity is not supposed to be the only thing that causes orthodontic tooth movement by bone remodeling. Rather, we can consider piezoelectricity as a means of tooth movement only during initial stages of the orthodontic force application. Later on, it is the pressure tension theory that plays an important role in orthodontic treatment. We can't completely eliminate the piezoelectric theory. Yes, in response to the piezoelectricity also there is the remodeling of the bone, but it's not for a long span because the streaming potential and piezoelectricity is only of a shorter duration. It has a rapid decay rate and reversal of the electric potential once the orthodontic force is removed. Okay, this is about piezoelectricity or bioelectric theory of orthodontic tooth movement. The next important theory of orthodontic tooth movement is fluid dynamic theory or blood flow theory. This theory was proposed by Bean. According to this theory, the periodontal ligament around the tooth consists of interstitial fluid in it, along with the cellular component, the mucopolysaccharides and the blood vessels. We have interstitial fluid present in the periodontal ligament. Whenever an external force is applied on the tooth, like orthodontic force, what happens is there will be squeezing of this fluid out of the periodontal ligament, confined to its own space. That means the fluid is not expelled out of the periodontal ligament, rather it gets squeezed itself from its location. Once the forces are removed, the fluid is replenished from the local vasculature. But when the orthodontic force is a continuous one, when the orthodontic force acts continuously on a tooth, the interstitial fluid will be permanently squeezed out of the periodontal ligament and it will get concentrated around the root apex and the cervical area of the tooth, forming a film. This called as this film actually reduces the orthodontic tooth movement and it is called as squeeze film effect. Now, as the orthodontic force goes on act continuously, the localized vasculature which is compressed will be unable to replenish the fluid that has been squeezed out of the periodontal ligament. This will create a vascular aneurysms within the periodontal ligament vasculature, and there will be change in the local chemical environment of the periodontal ligament, which will be in favor of recruiting the osteoclasts. These osteoclasts will cause resorption on the side of the pressure and deposition on the side where there is no pressure or tension side. That means ultimately the process of bone remodeling is resorption on the side of inflammation and deposition on the other side. Okay, this is called as fluid dynamic theory or blood flow theory. That means the periodontal ligament with its content act as a shock absorber or hydraulic mechanism that will cause orthodontic tooth movement in response to the orthodontic forces. We can combine these theories and put it under biological reactions to orthodontic tooth movement in this way. In response to orthodontic force, there will be biophysical reactions like bone deformation, compression of periodontal ligament, and tissue injury. These things will lead to production of first messengers like parathormone, the prostaglandins, neurotransmitters like vasoactive intestinal polypeptide. These in turn act on the cells, leading to production of secondary messengers like cyclic AMP, cyclic GMP, and increase in the calcium ions, which will lead to increase in the cells of resorption on the pressure side and increase in the cells of deposition, that is osteoblasts on the tension side, leading to bone remodeling. As the sockets get remodeled, the tooth will move within the remodeled socket. This is one cascade of biochemical reactions that are occurring. When we take orthodontic force, there can be even a direct inflammation due to tissue injury, leading to production of the inflammatory mediators, and ultimately bone remodeling and orthodontic tooth movement will occur. Apart from that, as I told you earlier, in response to orthodontic force, directly due to the piezoelectricity also, there will be remodeling of the bone, which will lead to orthodontic tooth movement. So these are the cascade of biochemical reactions that occur in response to orthodontic tooth movement, whose ultimate goal is remodeling of the alveolar bone socket in which the tooth is present, ultimately leading to the movement of tooth. Okay. Now, in response to orthodontic tooth movement, does the tooth move continuously? Definitely not. Why? Because the optimum orthodontic force is around 20 to 26 grams per square centimeter of root surface area. Now, even though when we apply this optimum orthodontic force, due to the surface irregularities present on the surface of the root or along the alveolar bone surface, which is facing or which is giving attachment to the periodontal ligament, the force which is optimum at one region of periodontal ligament might not be optimum at the other region of periodontal ligament. That means there will be heavier force in concentrated in certain areas of the periodontal ligament, which will lead to something called as hyalinization. That means whenever an orthodontic force is optimum, that is around 20 to 26 grams per square centimeter root surface area, then the tooth will move easily by direct resorption, we call it as. Whereas when the force is heavy, that is when the force exceeds this optimum range, then there will be something called as hyalinization. This hyalinization will lead to loss of cellularity in that portion of periodontal ligament, and the fibers will get degraded. Blood vessels will spill their contents in the periodontal ligament space. That means we don't have the local macrophages to get differentiated into osteoclasts to remove the necrotic bone. Rather, the osteoclasts will get differentiated from the marrow spaces and get recruited into the area of periodontal ligament where the hyalinization is occurred, and thereby they will remove the hyalinized tissue. That means the resorption that occur in the area of hyalinization is an indirect resorption, and the osteoclast has to come from the marrow spaces rather than from the local vascularity. So whenever the force is optimum, we have a direct resorption due to the osteoclasts that are differentiated from the local vasculature, whereas when the forces are beyond the optimum range, there will be a hyalinized tissue, that is acellular tissue, where the macrophages or the osteoclasts should come from the marrow spaces to remove this hyalinized tissue. This is called as indirect resorption. Indirect resorption is a time-taking procedure, whereas direct resorption occurs easily. That means the orthodontic tooth movement is not a smooth and a continuous one. There are stages of rapid growth, stages of halted growth in order to remove the hyalinous tissue, and again the stages of rapid growth. This is how the orthodontic tooth movement occur. So accordingly, we can classify an orthodontic tooth movement into three stages like first phase, second phase, third phase. Different authors classify these stages in different types. According to Burstone, it is initial phase, lag phase, post-lag phase. According to Reaton, it is the stage of pre-hyalinization. The second stage is the plateau stage or stage of hyalinization, and the third stage is the stage of post-hyalinization. According to Story, it is first phase, second phase, and third phase. So the point you should remember here is the orthodontic tooth movement does not happen continuously in a same fashion at a same rate. There are periods of accelerated movement, plateau phase or a halted movement, and then again the movement will be accelerated. That is, there are ups and downs in the movement of orthodontic tooth movement, mainly due to the phenomena called hyalinization, which occurs in response to heavy orthodontic forces or orthodontic forces which are beyond the optimum limit of 20 to 26 grams per square centimeter of root surface area. When we plot a graph with displacement of tooth along the y-axis and time along the x-axis, we have three phases of tooth movement. First one is initial stage or initial phase. This occurs due to the movement of tooth within the periodontal ligament space. Once the tooth has moved within the periodontal ligament space, then the tooth will undergo a lag phase where undermining or indirect resorption occurs due to hyalinization. This phase will continue over a prolonged period of time, after which once the hyalinous tissue is removed, again the tooth will show a rapid phase of movement which is called as post-lag phase. Okay. So don't be overzealous in putting heavy orthodontic force in order to move a tooth rapidly. You will be actually reducing the rate of tooth movement rather than increasing the rate of tooth movement by putting heavy forces. So the more optimum the forces are, the more will be the rate of tooth movement. Just make a note of it. Now, we have different kinds of orthodontic forces. See, forces can be used to move teeth alone, or they can be used to control the growth of the jaw even. So the forces which we are using to move the teeth are called as orthodontic forces, whereas the forces which are heavier and are used to control the growth of the jaws is called as orthopedic forces. Whether a force be a orthopedic or orthodontic, we have two kinds of forces. One is continuous, one is intermittent. Continuous forces are delivered by fixed appliances, whereas intermittent forces are delivered by removable appliances. That means with fixed appliances, the force that is applied will not fall to zero in between the appointments, whereas with removable appliances the force will fall to zero in between the appointments. That's why the forces used in fixed appliances are continuous forces, whereas the forces used in removable appliances are called as the intermittent forces. Even the orthopedic forces will also come under intermittent or interrupted forces because they are used only for about 10 to 12 hours per day and not continuously. Whenever an orthodontic force is light and continuous, it causes less compression of the PDL, less pain and discomfort to the patient, no hyalinization, more effective and faster tooth movement. Whereas a heavy intermittent force will cause more damage to the periodontal ligament, delayed tooth movement, more discomfort and pain, more amount of hyalinization, and rate of tooth movement will also be slow. That means for an orthodontic tooth movement to be effective, a force should be light in magnitude and should act over a prolonged period of time. whereas the forces which are heavy in magnitude and short duration of time are not effective in tooth movement. Rather, they will become deleterious to the supporting parodontium. Okay. Now, you can see the tabular form, which will give you an information regarding what are the changes that are happening in response to light forces and heavy forces as time lapses in the periodontal ligament. Now, what are the factors that are influencing the orthodontic tooth movement? The first one is analgesics. These are the non-steroidal anti-inflammatory drugs like aspirin, diclofenac, aceclofenac, ketorolac, ibuprofen, nimesulide. These are the drugs which actually reduce the orthodontic tooth movement. Why? Because usually you know that orthodontic tooth movement is mainly results due to inflammatory process, as non-steroidal anti-inflammatory drugs causes reduction in the inflammation, thereby the tooth movement will also be reduced. Okay. Similarly, patients with rheumatoid arthritis also have a altered tooth movement. The patients with rheumatoid arthritis will be having a prolonged use of steroids and non-steroidal anti-inflammatory drugs, which in turn reduce the rate of orthodontic tooth movement. That's why never use a painkiller or a prolonged period of time when you are doing an orthodontic treatment, because this will inhibit the cyclooxygenase pathway, which is the major pathway for production of prostaglandins. Thereby, no prostaglandins, no inflammation, no bone resorption, and reduced or zero tooth movement. If at all you are using non-steroidal anti-inflammatory drugs, they should be used only for a minimum period of 3 days, not more than 3 days. Okay. Now, patients with cystic fibrosis have a less calcified bone. That means more of osteoid tissue is formed. Similarly, in the patients with osteomalacia also, we have a less calcified bone. That means the resorption process will be easy. So the tooth movement will be faster. Even in primary hyperparathyroidism also we can see a faster rate of tooth movement because of increased rate of resorption. In patients with osteoporosis, again we have two different kinds of tooth movement. A patient with osteoporosis might be a treated case or untreated case. Patients treated with osteoporosis using sulfonamides will show more resistance to tooth movement, whereas untreated patients of osteoporosis will lead to increased rate of tooth movement. Similar is the case of osteogenesis imperfecta, where you can see a less calcified bone through which the tooth can move very much faster, because the process of bone resorption occurs by first decalcification, degradation of the the organic component, and degradation of interstitial tissues like mucopolysaccharides and tooth movement. As in a less calcified bone, there is no stage of decalcification, the tooth movement will be rapid. So these are different factors. There are many other factors, but for this stage it's enough to understand these aspects of, or these factors which are affecting the orthodontic tooth movement. So tooth movement is actually a physiologic phenomena, but by orthodontic treatment we are stimulating this biological phenomena and utilizing it to move the teeth into an optimum position to achieve an optimum occlusion. That is how, via various biochemical reactions, that orthodontic tooth movement occurs. Okay. So it's always essential to know the biological processes at the root level to execute any treatment plan effectively. Similarly, it's always essential to know how a tooth moves and what is the actual processes involved in the movement of the tooth in order to institute your mechanotherapy effectively. So that is today's class on biology of orthodontic tooth movement. Thank you.